It's another driver of cost that we don't talk enough about. Mental illness and addiction. So this past year, the first ever report by the Surgeon General under the title of Facing Addiction. Now, full disclosure, I'm on the board of another not-for-profit organization by the name of Facing Addiction. And let me just tell you, there is no coincidence that the Surgeon General report used Facing Addiction in their title. There was a lot of collaboration between that organization and the Surgeon General. And that report came out in this past year, highlighting some very important things about addiction. But in that role on the board of Facing Addiction and in my interests, I hear a lot of stories. And we all hear a lot of stories. Just last week, I heard from a friend of mine who just lost his 27-year-old daughter to addiction. 27 years old. And those stories are crushing. But here's the deal. These issues are more than just sad. And here's the part that we don't talk enough about in this country, and the report does. There are financial implications to this addiction environment. And we're starting to talk about it from some respects, but the reality is we do a lousy job of recognizing and addressing substance abuse disorders in our mainstream healthcare settings. You pick any of the three: health plans, the physician or clinical area, or the hospitals. Really, quite honestly, nobody's doing a very good job of identifying and addressing substance abuse disorders. Secondly, having a substance abuse disorder, and here's the connection, it doubles the odds that a person will develop a chronic condition. And we've already demonstrated that's incredibly costly. And those chronic conditions can be anything from arthritis, chronic pain, heart disease, stroke, hypertension, diabetes, asthma. All of those things can be either triggered by or enhanced by, not exclusively, but in part by addictions. And thirdly, the number of people living with and dying from mental illness and addiction is growing rapidly. Now, we hear a lot about this today in terms of heroin and opioid, the opioid crisis. And there's some really compelling data along those lines. One of those pieces of data, 259 million prescriptions were written in 2012 in this country. That's more than enough to give every adult American their own pill, their own bottle of pills. 259 million. And that was in 2012. Fast forward to today. So we hear a lot about that, and that's become kind of the sexy issue to talk about opioid. The politicians have jumped on that, and again, rightfully so. But here's the issue that relates to our healthcare system that we're not talking about. It's not the only issue. The health consequences and the healthcare costs associated with alcohol abuse were and are significant long before the opioid crisis, quote unquote, occurs, before the opioid issue emerged onto the scene. The graph that you do see shows a dramatic increase in mortality by poisoning, suicide, chronic liver disease, and cirrhosis. All of those conditions can be linked to both mental health issues and alcohol abuse. All of that was addressed in the Surgeon General's report. And they talked about the fact that one of the things that we need to do in terms of the treatment is catch it early. Yet how many people have addiction treatment on their radar screens in terms of managing the total cost of care? How many value-based payment experiments incorporate substance abuse and mental health components into the mix? There are very few. Instead, we're paying attention back to what we started with. We're paying attention to what we know how to do, what we're comfortable with in the acute care sector. Consider the CMS pilot on joint replacement. If you're one of those 800 or so hospitals that are participating in that project, I know, and you know, it's an incredible amount of work. because it's hard to do bundle payments and it's hard to bring the parties together. And again, I've sat at those tables and I know what it's like to look at that data and bring hospitals and physicians and health plan together to look at data differently. But if you think about that, and we ran the math here, you think about pilots are designed to be able to run some data and then if it makes sense to extrapolate that to the rest of the industry. So what's the ROI? We ran this math. If the pilot project results of this CJR could be replicated across all joint replacements nationwide, Medicare would save about $400 million. So that might sound like a lot, but that's not. If you think about it, put that into context. $400 million represents 0.01% of the total healthcare spend. That's the equivalent, about the equivalent of the annual revenue of one 200-bed hospital. And yet, and again, I know that surgery is an expensive thing, and there's probably folks in the health plan world that's sitting out there saying, yeah, but joint replacement surgery is expensive. My argument is all that effort going toward joint replacement bundles and all those kinds of things, if it adds up to 0.01% in healthcare spending when we're busy, is that the best use of our scarce resources? And what could we save if we took that same energy and focused it on chronic conditions? Consider just one example for a second. If we had a 13% reduction in the number of people with uncontrolled hypertension, we would save the healthcare system more than $25 billion a year. And back to the triple aim, and improve many lives at the same time. Again, remember the 550 rule. My question for ourselves in this industry is, are we working on the right things? And the data would suggest that we're not.